Thank you very much, John, for your kind words, and thank you indeed for the invitation, and I'm glad to be continuing your lessons from Scotland. I'm actually delighted because not only will I be here talking to you, but I have already learnt a lot about the similarities of our two countries, probably more similarities than differences. We have the same challenges, which I shall talk you through, some of my challenges in Scotland, and we also are, I think, aiming in the same direction for many of our solutions. So I look forward to the panel. I always enjoy speaking to audiences because I always take something home as well, so we hopefully have time for questions and answers. And I'm a practicing obstetrician and gynecologist, which I now have to call OBGYN, as you like your acronyms here. And I, as Chief Medical Officer for Scotland, I also have to point out that's for the country of Scotland. And I am, although I work for the government, I am independent of government. So my actual locus is for the people of Scotland, which I think is extremely important. So my children, they understood my previous job. They knew that when Mummy went to work, she was helping ladies who were having babies. And my son and I were walking into schools very soon after I was appointed as Chief Medical Officer. And he said, "Mummy, I don't really know anything about this new job of yours. But it's about keeping people healthy, isn't it?" And I said, "Yes, George, that's very good it is." He said, "You're not going to ban sweeties, are you?" And for those of you who know me, I'm not going to ban wine either, but I would be grateful if you didn't tweet that. So I thought I would tell you a little bit about my country of Scotland. We have 5.4 million people, so not dissimilar to Alberta. We have a budget of £13 billion, which is around 40% of the total budget for Scotland. So similar again in proportion on what we spend on healthcare. In contrast, my poor education colleagues have to put up with a mere 3.6 billion, and we have ring-fenced money for the NHS in Scotland. What I should also explain is, although it is free at the point of care, NHS is taxpayers' money. And the difference, though, that I have come across is that along with our nurses and paramedics, allied health professionals, all doctors within the Scottish system are salaried. So we have a salaried system for all of our medical professionals. The primary care works slightly differently, but it's government money and they are paid per capita of their practice size, but those are averaged. So that seems to be the main difference in the way the two systems run. We have, as you see here, 14 different types of tartan on this map. That is because we have 14 different health boards, so I suppose you have your zones in Alberta, and the different tartans, as you will see in a moment, are not a coincidence because we would appear to have different ways of doing things across the country. We have 8 support boards, so that would be our education, our NHS procurement, for example, and we have had health and social care, which John tells me I need to translate for you as health and continuing care, integrated since 2016. So we have our challenges, as have you. This is our projected percentage change in the age of the population between now and 2035. So we think that our 65 to 74-year-olds, that number is going to increase by a percentage of 46% over what it is at the moment, but a huge increase in our number of people living over the age of 75, while you and me, in that people who are working, earning the money to pay for the health care, you can see that that number is, in fact, if anything, going to decrease. So I believe you have similar statistics here. And of course, living longer is not a bad thing. I don't like the negativity around the burden of people in their older age, because of course we should be celebrating the fact that our healthcare is so good that people are actually living longer. But in fact, it's longer, healthier lives that we're aiming for. So I have my challenges in Scotland. Our geography is beautiful. That is the bridge from the Harry Potter films. Some of you may recognise it. But we have from beautiful scenery like this to large inner cities with very deprived populations. And our inequalities are really quite significant. This is Edinburgh. This is where I live. We have a lovely new tram system. It runs from the airport out over here on the left, right through to the centre of Edinburgh. And if you live a few stops along from the airport, it's beautiful, it's leafy, it's green, and there are lovely schools and parks, and the people there live on average about 79 or 80 years if they are a man or a woman. But if you get off the tram 2 stops away, you'll see that that life expectancy is actually different by a factor of 11 years for men and 8 years for women, just within a tiny 2-mile radius. And our bigger city of Glasgow has equal inequalities in its population lifespan. So I have my challenges as Chief Medical Officer, my son would tell you. And we know, of course, that the reason for some of this, the problems is that our deprived communities then, of course, do very much worse with their health outcomes, and that's a statistic from my Scottish population with cancer. And we have our problems with Scotland's unhealthy relationship with alcohol. This is our alcohol-related mortality rates. The whole Scotland figure is purple. The men are blue at the top, the women red at the bottom. And that blip that you see in 2003 and the then subsequent fall in alcohol-related mortality is due to us bringing in a ban on multi-buy offers on alcohol in the supermarket. So it would appear that if you charge £12 for 3 bottles of wine, people will buy 3 bottles of wine. If you charge £4 for 1 bottle of wine, people buy wine 1 at a time. And that legislation to prevent these multi-buy offers on alcohol, we believe is responsible for that drop in mortality. We have then, perhaps you've seen much publicised because the Scottish whisky industry weren't that keen on it, introduced minimum unit pricing for alcohol. So 1 unit of alcohol has to sell for a minimum of 50p. We were having those large bottles, I really hope you don't have them here, of the high-strength cider that contain 20 units of alcohol in 1 bottle and would cost $2 or $3. So those now will cost $10, $11, and so actually people don't drink as much. And we believe that world-leading change in our alcohol pricing will result in further alcohol deaths. And this slide just shows that those are our most deprived people at the top of the graph there, and these are alcohol-related admissions, and of course it much more affects our deprived communities. So what about our beautiful food, as well as our much loved whisky? And this is our larder in Scotland, and unfortunately, though, that is not what everybody eats. And so we have, as I know you have too, a problem with our obesity rates, and we are being quite bold in Scotland. 2/3 now of our adults are overweight, with 29% of them obese, and the little infographic on the side essentially says that if you eat the wrong stuff, you to have an overweight and obese population. So we've just consulted on a very bold, I was going to say obesity strategy, but as somebody pointed out, we weren't actually striving for obesity, so we have managed to call it a diet and healthy weight strategy. And those and measures such as the multi-buy offers that I told you about with biscuits, and also some fairly aggressive bargaining with our industry about high-fat, salt and sugar reformulation. So we will do quite a lot of nudge from the bottom, but also we're prepared to work really quite hard with industry to improve the situation that I'm showing you there. We have some success. These are smoking rates, England, Scotland and Wales, and you'll see that we are aiming to come to a smoke-free nation, less than 5% of Scotland smoking by 2034, and I think we'll get there. The inequalities there, story is very good, because actually our poorer communities are giving up smoking more rapidly than our wealthier communities. There are more people smoking, but that's a good story. And the other good story is our physical activity. These are UK Chief Medical Officer guidelines. Feel free to steal them. They're freely available on the internet. We have them for babies and children. We have them for 5-year-olds to 18-year-olds. We have them for adults, and we have them, possibly my influence, we have them for pregnant women. So these are designed to be the information that healthcare professionals would give to people, but actually with social media they've been shared all over the world, because actually they're very accessible, and I possibly might ask you to give me a standing ovation at the end of the talk, just, you understand, to get you off your feet. So I've actually been asked to talk about realistic medicine, and so I see that you will have on your programme the little infographic that we produced. So Chief Medical Officers produce a report every year, and the report traditionally has the health of the nation in it, which, as you saw, isn't that brilliant a read. I did a straw poll of my doctor friends and said, have any of you read a Chief Medical Officer's report? And that conversation didn't last terribly long, and so I decided to do something a little bit different. So when I had been appointed, I went round the country and I spoke to doctors mostly, but also all professions across the NHS, and I was hearing from them that they were finding it really difficult practicing the medicine that they had wanted to practice when they had left medical school. They were stressed, they were overworked, they didn't have enough time with their patients, and they felt sometimes that they were over-diagnosing, over-treating, and doing things to people because they didn't, without necessarily having time to explore with them what those people really wanted. And at that time, I began to read quite a lot of literature about what the choices are that doctors make for themselves. So doctors given a terminal diagnosis, that is, they react rather differently to that than you might expect. So doctors with a terminal diagnosis, 88% of doctors would not have hemodialysis. 67% of doctors would not agree to be admitted to intensive care. And 95% of doctors would not sign up to have CPR. And what I wondered with those figures is what is it that we know about those interventions that would mean that we would choose not to have them, or perhaps advise our families not to have them, but yet that is not the rate at which doctors talk to people, their patients, about those interventions. And so I decided really to explore with my doctors in Scotland, and they were sent all a copy of the first report on the left, Realistic Medicine, and within it had that infographic that you see that I put on the front of the third one. I asked them if we could change our practice to shared decision-making, a more personalised approach to care to reduce harm and waste, unwarranted variation in practice and outcomes, harm, risk, managing risk better, and all innovate rather than just go to work and come home again. Could we go to work and actually see if we could improve what was there? So I suppose people say, well, what's realistic medicine really though, Catherine? And I meet a lot of people when I'm out and about. I was in the west of Scotland and I met a man who'd had a knee replacement. And I said, how's your new knee? Oh, well, doctor. I said, oh, is it sore? Not really. I said, well, can you walk? Yeah, I suppose so. I said, well, you don't seem very pleased. He said, well, the thing is, doctor, I like to stand on my doorstep to talk to my neighbour, and my knee got very sore. So I asked them for a grab rail, and they gave me a bloody knee replacement. And I still can't stand on my doorstep because I still don't have a grab rail. So I'm sure that the very well-meaning orthopaedic surgeons did not operate on a man who did not have osteoarthritis of his knee, but what they did do was not explore what he actually wanted from his health care. So I have a friend who's a care of the elderly physician, and he runs the hospital at home service. And the hospital at home service keeps people at home, as you might expect. And I know that you have those in Alberta, and that you're expanding as we are, because in fact they're cheaper than keeping people in hospital. They prevent people being admitted to hospital. The drug bill is less, and amazingly the patients like it better. What a surprise. So we, like you, are aiming to have people kept at home. So Graham was on call as the care of the elderly physician. They run the hospital at home from their own hospital nearby. So he was on call, and he got a call about a man who was a very frequent attender at the hospital. Everybody knew him because he had quite an interesting disease. This man had pigeon fancier's lung, and he was in and out all the time, got a bit worse, more breathless, admitted again. Every time he came in, they had the conversation with him. You really need to give up the pigeons. The dust on the pigeon's feathers is making your lungs worse. You're going to be in and out of hospital. Your lung function's getting worse. You're not going to get better until you give up the pigeons. Every time, in and out. So Graham got this call and he thought, I wonder if that man could stay at home this time. We've got the hospital at home service. I'll go and visit to see. So he went, and he went into the man's home, and he was really very breathless. He thought, oh, I'm going to have to bring him in. And he started the conversation. He said, you realise, you know what's causing this. You've been in, you were only in 3 weeks ago. You really need, and he could see the man's daughter sort of beckoning him. Could I have a word, Dr. Ellis? So she said, Doctor, no one from the hospital has ever been to my father's home. I wonder if you would like to see his back room. And this room is stuffed full of trophies, and those are portraits of his winning pigeons. Because this man in a tiny little house in the west of Scotland was once the UK champion pigeon racer. And she pointed out the window and she said, do you see those sheds, Doctor? There are 200 to 300 pigeons in those sheds. Some of them are worth £30,000. My father spends hours with his pigeons. He talks to them, he feeds them, he waters them, he loves them. My father would rather die than give up his pigeons. And it doesn't matter how many doctors tell him. So Graham walked out of the back room, into the living room, hitched up the IV antibiotics to the standard lamp, gave the man a shot of cortisone, and let him stay at home with his pigeons. And that is realistic medicine. So my story continues with my next report. Because once I wrote out to the doctors, they all wrote back to me. And they wrote back to me, the primary care doctors wrote back and said, well, thanks very much, Dr. Calderwood. We've been practicing realistic medicine for decades, but we sort of thought we had to keep it under the radar. So thanks for saying that it's okay not to do everything for everybody and to have a conversation with them about what they might want from their healthcare. Interestingly, though, the ED doctors were the second biggest number who wrote, because they said, not very realistic at 3 a.m, not very realistic when somebody's toppled over at home, either literally or metaphorically, and nobody has talked to them about their congestive cardiac failure being a life-limiting condition. And nobody has talked to them about the fact that if they were admitted where they wish to be admitted to intensive care, and we're standing at 3 a.m. with the family all gathered around and nobody knows, because nobody has talked to them. We would like some more realistic medicine in ED. And the nurses wrote to me and they said, we're much more realistic than the doctors anyway. Can we have realistic medicine, please? And the pharmacists wrote and they said, could you change it, please? We'd like it to be called realistic medicines. And so the response from the people I had written to right across, all paramedics, physiotherapists, midwives, wrote and said that we really would like to get involved in talking to people more about their priorities, more about their care. And with the second report, then we talk really about changing the culture. So I ask some questions. Do we really listen to our patients, find out what matters to them, and help them make an informed choice? Do we address over-treatment? Do we challenge variation in clinical practice? And I'll come and talk about that a little bit in a moment. And do we offer higher value care? And I know Braden's going to talk about the stewardship of our public money. It's public money here. It's public money where I work. What I talk about is high value care, but if it offers no value to the patient, it may be very high quality, but it's not high value care if they aren't getting value out of it, like my man with his knee. So I think we wanted really to talk about all of those aspects which make up the principles that I originally talked about. So people say to me, but Catherine, I would love to have all those long conversations you're talking about, but I don't have time. How could I possibly have time to have some kind of shared decision conversation? So when you look at the literature, these are cancer diagnosis patients. It's not the first appointment, it's follow-up. So we looked at how much time doctors actually spent talking, and they spent 44% of the consultation talking. The patients get to ask questions 0.0% of the time, and the doctors spend the 5% of the time answering those questions. So I'm sure you don't have any talkative doctors in Alberta, but I wonder if we actually looked about how we're communicating. And I was in Portugal the week before last talking to an audience of communicators in healthcare. That was quite a challenge, speaking to a lot of communicators. And they have been banging on, they tell me, about this for about 30 years. They don't get much traction for some reason, but they say that we need to teach people how to communicate, that it's not just an assumption that because you work in healthcare and have chosen to do that, that you will be good at getting the messages over, nor indeed at, listening. And so I challenge a little bit, and I do know, I'm being a little facetious, that my own doctors are absolutely pressurised for time, and everybody has too much to do and too much work. But my GP colleagues, who only have between 7 and 10 minutes for each one appointment, one of them jumped up and she said, how can I do this in 10 minutes? And interestingly, the other corner of the room, another GP jumped up and said, yes, but isn't that the beauty of being able to bring somebody back the following week? And actually, really, for some of these very big decisions, should you be making them sitting there and then in the room? Do you perhaps not need to go away and talk to your family and discuss things? And actually, sometimes using the time differently might be the way forward. So the most interesting one of these are all deliberately from the 1970s and 80s, because it's been a problem for a long time. 54% of patients' complaints and 45% of their concerns are not elicited in the consultation. And in 50% of visits, the patient and the doctor do not agree on the nature of the main presenting problem if you interview them both straight after the end of the consultation. You'll not have any doctors like this in Alberta, I know. Doctors frequently interrupt patients so soon after they begin their opening statement that the patient fails to disclose any significant concerns. So the communicators and I get on extremely well, because they like the fact that I've started to talk about communication being something actually that perhaps we need to concentrate on. It's not a fluffy addition. And maybe some of you will be able to think of some of your colleagues who are extremely good communicators, and then perhaps you know some who are less gifted. So we really need to tackle some of this, because I think some of their communication leads to the over-intervention and perhaps not establishing people's priorities from their care. But we also have a big problem because of the health literacy. So these are UK figures. UK working adults, 43% would not be able to work out the dose of paracetamol simple analgesia for their child from the instructions on the side of a bottle. 28% do not understand the information on the screening leaflets that we in the government post through their doors on their 50th birthday to invite them for breast screening or bowel screening. And our response to that is that we post screening leaflets inviting them for screening through the doors on their 50th birthday. We have very poor skills actually in more than half the population, those ones at the top, 23% UK working age adults, where people will not understand what you mean about the dose or the frequency of taking medicines, and another 32% where actually they really will only understand if you lay it out with pictures and very clear instructions. And how many of us really understand the true literacy level of those that we are seeing if we're practicing. The reading age, the average reading age in the UK is a reading age of 9. You'll see that 4% of people have no health literacy at all. 1 in 25 don't know what their heart, lungs, or indeed in my world, womb is for. And so we really do have a challenge, because if, I don't know your literacy levels, but certainly my audiences do not know that that is often the level that they're dealing with. And of course, people with very poor literacy are extremely good at hiding that, because that's what they do all day, every day. I wouldn't, though your assumption is immediately that these are of people of low educational attainment. I'll tell you the story of the graduate from Oxford with French and German degrees who phoned me up because she was pregnant and she'd had some screening results. And she phoned and she said, "Oh, Catherine, I don't know what to do. I've had these results and it says that the baby's at high risk for spina bifida." I said, "Oh, right. What's the risk? What was the test? What's the risk? What risk have they given you that?" And I started, and she said, No, can you stop? I said, "Why? What?" She said, "I really just wanted to ask you what spina bifida was." And I thought, what? So apart from the fact she's consented for screening tests about a condition she doesn't know what it is, Why would I expect somebody who's done French and German at university, who stopped doing any kind of science aged 14, to know what spina bifida was? It's barn door obvious to me, obviously. But why was my expectation that because she had a high level of education, that would have been something that she would have ever come across? And so I wonder if we're assuming all sorts of things from our education system, and also from what people are actually understanding about what we're talking to them about. So you can get these from the internet. We have 2 plans in Scotland. Making it easy was our first health literacy plan, and then we thought we'd make it easier. And so if you want to read those we're embedding knowledge about, I suppose, lack of health literacy in all of our policy documents, but also ways to come around those. And if we've time, we can talk about teach back programs, very simple, easy ways of ensuring that people have understood information that they're given. We also are using our libraries. People in Scotland visit libraries more than they go to Premiership football matches and the cinema put together. So we have health literacy resources there. We have trained up our librarians, and we are using those as a very oft-used source of information for people to actually start to help with our health literacy in Scotland. So in the environment that I'm describing to you, of course, things are very difficult, but I would put to you, and we can talk about this if we've got time, that what I believe now to be evidence-based practice is only truly evidence-based if it takes into account the relevant scientific literature. That's what we've always had. We always need clinical judgment, that person sitting with the patient. But clearly and very crucially, we need the patient's values and preferences. What will be a choice made by one person will not be necessarily the same choice made by someone else who has a different idea of risk or for whom an outcome would be devastating, whereas someone else would tolerate it. And so my colleague, John Kinsella, who wrote part of the third report for me, talks to us about, he chairs our guidelines committee, that the guidelines are made for diseases, not for people. And that living in the real world, actually sometimes with discussion and patient preference and values, it is of course okay not to follow the guidelines for that individual. So all of my colleagues talked then to me about having realistic medicine. And we had realistic healthcare, then they wanted realistic health and social care. But what they were worried about was that the public were not going to be realistic. So I took a bit of a risk, and we have something called a citizens panel in Scotland. We use it for different things. So it's 1,500 people. It's representative of the country. So men, women, age, demographics, rural, urban, etc., education level. And we asked them some questions. We asked them, first of all, what they thought made a good doctor. And Dr. MacLeod here will be pleased to hear that 71% of the Scottish population thought that a good doctor should have a medical degree. I'm not sure about the other 20. Anyway, don't worry about that. So, and my GMC was quite pleased too. So the 71%, they wanted them to be knowledgeable and competent. Fair enough, I thought. Good, well done. 64% said that they thought that a good doctor was a good listener. And nobody said, my doctor gives me everything I want. I go in, I get a pill, I get a test, I get a procedure, I get a referral to the nice shiny hospital. A good doctor is a good listener. So we asked them then if they would feel comfortable asking their doctor about their treatment, their options, etc. And you'll see these 3 questions were slightly subtly different, and in all of them, about 90% of people said, yeah, I think I would quite like to ask. I feel fine about asking. And then we said, well, have you actually asked? 2/3 of them have actually asked about their treatment and care options. 64% have actually asked about risks, and 54% have actually asked about what it would mean for them. So again, where is the disconnect? My colleagues, others in healthcare, very happy to give the information. The patients, the people in Scotland tell me that they would be happy to ask, but they don't. So there is a miscommunication perhaps there that we need to overcome. So we're encouraging the use of these questions in Scotland. We've made some little credit card-sized cards. We've got them on posters in our outpatient departments all over the country. And so we're asking people themselves to ask, or we're asking the healthcare professional to go through the consultation with some of these questions framed if the patient doesn't ask them. Is this test, treatment, or procedure really needed? What are the potential benefits and risks? What are the possible side effects? Are there simpler, safer, or alternative options? And what would happen if I did nothing at all? So I met a young surgeon on the train. He recognised me. It's a disadvantage, particularly if you're going to smack your child in the street, I assume, which I wouldn't be. And he said, I read your report, Dr. Calderwood. I thought it was very good. He said, I hope it's okay, but I've just added in something when I'm consenting somebody for an operation. I said, oh, what do you say? And he said, well, I go through everything. And then right at the end, I say, you do realise you don't have to have this if you don't want it? I said, yeah, brilliant. And he said, and it is surprising how many people say, really? But I was sent here, and my daughter said I should go, and then the GP sent me to the hospital, and you're a surgeon, and what do you mean I don't have to have it? Really? And then he talks to them, and off they go. So again, is there an assumption? The doctor knows best? And do we really explore with people, even before they get there, was it the right thing for them? I heard yesterday of a 94-year-old who had some problems and who then ended up in hospital for a very long time and ended up with an ileostomy. And she said when she was just ready to go home, if I had known that coming in here would mean me leaving with a bag, I would never have agreed to it. I'm blind. I have arthritis, I cannot deal with it, and nobody told me that this was going to be the end result. I might have lived with what I had. So we have nice examples of communicating. This is our neonatal unit in Glasgow, one of the big ones, so it's a nice little acronym helping us grow group. And the staff noticed that the parents are very stressed when their baby's in the neonatal unit. They often can't stay, they're often travelling. So what they did was they put a little whiteboard by the baby's cot. And when the night shift go off, they leave a little message for the parents about the baby, how it's been overnight, fed, not fed, wearing a blue baby grow, whatever. And the baby leaves them a little cheerful message. And when the parents come in, they want to communicate, and the staff nurse isn't there, that's usually there, so they write a little note, and back and forwards it goes. And then one of the dads was travelling a lot, and he said, I can't bear it. So they set up some Skype, they dial up, and dad can see baby, and baby maybe sees dad. And so they have measured some of the outputs of this, and they have measured a measurable decrease in parental anxiety from a tiny little whiteboard which costs, I don't know, a few dollars. And parents tell them that they sleep better because they're really feeling like they're not there, but they're going to be communicated with when they can be there. Simple, easy, and it's just communication. So this was just to remind me that because we have embedded our realistic medicine principles into all of our medical schools. We have 5 medical schools in Scotland, about 1,000 medical student intake a year. We traditionally export doctors because that's too many for us in Scotland, and I would actually like some of them back, please, because you seem to have stolen lots of them in Canada. And each of our medical schools are now talking to the students around the principles of realistic medicine because we obviously need this to be something that continues. So Dr. Yu Verna, who I've spent a lot of time with in the last couple of days of AHS, she's very keen on this as well, this quadruple aim. So you're all very familiar with the better outcomes, lower costs, and improved patient experience. But what I've talked about then in my report this time is valuing our workforce, because they are stressed and overworked. There's a significant amount of research on physician burnout and other practitioners as well. We have people leaving, we have people retiring early, and we also know that if you are unable to look after yourself, or you're not running on top power yourself, you are not going to look after your patients. You cannot give care to somebody if you are not feeling like caring yourself. But I wonder then, do we understand our organisations? Those of you at the back won't be able to see this, but I'm absolutely certain there's no department in Alberta with any of those complex interactions. This isn't a real example, she says frantically. Do we really understand people? Do we also understand when they are having a bad day and why they might be having a bad day? Do we compensate a bit for that for them? Do we let them step down from that horrible shift, the one nobody likes to do? And why don't I'll take that from you. You take the one that lets you go home a bit early. Are we a team? Do we actually, and this is not just applying to clinicians, this is wherever you are in whatever organisation you come from, this is wherever you are in IHE. And do we then value our own colleagues? Phone a friend? Is that acceptable? Because we know, certainly from the clinical point of view, that good, well-functioning teams will have better patient outcomes. It is worth any investment we put in to valuing our teams and valuing those people around us. So we really started some work in Scotland. We've got a project called Project Lift. It's open to everyone in the NHS in Scotland, from whatever grade, porter to consultant, from management, clinical, non-clinical, and we offer a little bit of coaching. It's done online, and if you want to go further, you can go a little bit further, and we also aim then to take off a layer of people who show some potential with some assessment to actually grow some future leaders. We have an issue. Again, I would hope this isn't the case in Alberta, but if you're a doctor that then goes into medical management, you appear to have been moved to the dark side, and you are not somebody that is really a doctor anymore. I'm sure that doesn't apply here. And so we need to value, as I say, every member of the team. We need to move away from that. Doctors need managers in the same way as everybody else does. And no lightning bolts. And that workforce as a team, and that understanding of each other. So we have some paired learning. We put clinicians together with non-clinical managers. They work together, they do shifts together. People understand their jobs a little bit better. That always makes for nicer environments. And we talk then about challenging unacceptable behaviour. We again, I'm sure you have nobody that behaves badly in any of your organisations. If you want to think briefly about the last time you saw someone getting angry inappropriately, shouting or moving a junior aside, treating somebody differently because they were not either as senior or from the wrong specialty or bit of the system. Maybe you can't think of anybody, I can. And I've been told then that that's okay, though, Catherine, because those tend to be those are the old guard, they say. Those behaviours, those will go away. Those people that shout and strop in theatre, those people, they'll retire. And I say, are we going to wait? We're going to wait for 5, but he'll be gone in 5 years. 5 years? We're going to wait for him to retire for 5. We're just going to leave him. He might retire in 5 years. He might try to stay on like they do. So what I would put to you is, and this is for everybody, those of us who stand by and don't call out the behaviour, those of us coming behind that behaviour, what are we demonstrating to the juniors, to the ones below us? If they see you not calling it out, everybody in the room knows. You say nothing. Does that mean it's actually, oh, I saw that, Dr. McLeod said nothing. Maybe it's okay to behave like that. Maybe when I grow up, I might start to behave like that, because we will not get rid of people when they retire if we don't call it out. So we have our Royal College of Surgeons in Edinburgh has a very nice campaign. Again, it's on the internet. Let's Remove It, it's called. We've joined up with the College of Surgeons as the College of Obstetricians and Gynecologists, because we, I'm afraid, the OBGYN are our big bullies. Our our trainee surveys tell us that. I don't feel very proud of that, but that's why I am really championing this Let's Remove It campaign. It's got some very nice ways of calling stuff out, but it's also got some very nice ways of helping distinguish what's acceptable, what's unacceptable behaviour. Sometimes a stressful situation, it's okay to raise your voice. So of course we're all learning. Improving work-life balance, we all need our work, I assume, that's why you all go. It must be something more than the money, one would hope. We all need family time with friends, relaxation. Do we ever give ourselves the little bit of time for ourselves? We all need all 3 bits. And unless you can give yourself all of them, you can't care for your family, maybe, but you certainly can't care for your patients. So sometimes you need to prioritize me. So I'm going to touch briefly on this and then talk a little bit about variation before I close. So when we talk about our health service and all the issues that we have to deal with, what of course we all know is that in fact most of the problems are not fixable by us. Social determinants of health are if you think of your own communities where actually the housing, the education, the family income is the problem. And we sometimes end up with medical solutions for what are societal problems. What we are doing in Scotland, though, is helping tackle some of that. We have put welfare rights advisors in some of our, we have 100, we call them deep end GP practices. They're the most deprived. In the most deprived communities, we've put in these welfare rights advisors. These are fairly low paid people. It's something that you can, it's not much money to achieve this. And as you can see from one pilot in 2 practices, 165 people got £850,000 worth of unclaimed benefit. People in poverty entitled to benefit that they couldn't receive because they couldn't navigate our system. And so we talk a lot about the social determinants of health, but are we helping people step out of poverty, which arguably might have helped them a lot more than whatever the medical services could provide. So I have a story, a young woman, she was on her own, 2 children. About 6% of our children in Scotland have what's known as holiday hunger. That means that in the school holidays they're not getting a meal, and so they are hungry. She had, through a glitch in the benefit system, she had been moved from one home to another, and the address wasn't matching up, and she had no benefits, no money at all for a fortnight. The children were on holiday, no food, and she was, as you would be, at her wit's end. No money, no way of getting money, and living in a homeless hostel with these 2 kids. She went to the GP, I know him, and she said, Doctor, I'm at my wit's end. I'm suicidal. She's crying. I can't see a way out. I cannot see a way out. I'm going to end my life. And he took a little bit of time and heard the story. And you know that is a medical crisis, somebody threatening to kill themselves in your GP office. You need to do something about that pretty fast. And the usual response would be that you would admit her for assessment. She might get admitted then after that. If she was a real threat, what happens to the kids? They get taken into care, foster homes, and you know the scene. But what Peter did, what he was able to do, because he has what's called a links worker in his practice, and she was able to take the woman, 200 quid loan very quickly, just there's the money, took her to a food bank, got food, took her to the housing office, helped through the glitch in the home situation. Home coming next week, kids stayed with her. Of course, actually, it wasn't a medical crisis at all. But our response usually, the only response actually a GP could give in their 10 minutes that they've got, would be the medical model. So those links workers, they're people with, they're often healthcare assistants. I think you have similar. So they're people with a health background, but they're not highly paid, and they just have access to all of these social care type services. So we're really trying, I suppose, to tap into what people really need. So I said I would talk then about our unwarranted practice and unwarranted outcomes. These maps were just, I realised they were only published yesterday. I've been using them on slides. And this is a map of Scotland with our primary knee replacements on it. The dark blue is lots and lots of knee replacements, and the pale blue is not very many. And that varies by a factor of 7-fold across the country. And the orthopaedic surgeons tell me that they say, well, those people in Dumfries down there in the southwest, they're very rural people. They wear their knees out awfully fast. We have to replace their knees a lot. We really do. And I say, well, and those people in Aberdeen, they're not wearing their knees out then. They don't need as many knee replacements, do they not? Is that a thing? So 7-fold variation in and you're remembering, by the way, they're not fee for service. You don't get any more money if you've done 25 knees in a month or 5. You just take your salary home at the end of the month. So that they're not incentivized, nor is the hospital incentivized by pushing through knee replacements. Variation of 7-fold. Primary hip replacements, variation of 4-fold. Cataract operations, variation of 3-fold. So we are publishing these maps. Those were the first 3 yesterday. We'll have another 7 by the end of the year. We're looking at childhood obesity. We're looking at rates of other surgical procedures are sort of the easy ones. We're going to look at prescribing. And when I look, which isn't public, we see variation everywhere. Variation in rates of GP referring to cardiologists, variation in rates of GP prescribing, variation in everything. And as I emphasize, none of this is driven by any kind of financial incentive, because that's not how my system works. So when you are concerned about variation, there is obviously more to it than some of the thoughts that people may have about income generation. So people then say to me, well, Catherine, if you like funnel plots, but look, those places are really wild, look at them. Those are tiny little places, those are the islands, look. You don't understand statistics. And I say, well, actually I do. And if you look along there a bit, look at those populations where there are 200 and 300 people, and look at the variation there. Variation there is 2- and 3-fold, even in the big areas. So I know that you'll maybe try this, and what will happen is your clinicians will say, they'll say it's the patients, first of all, wearing out their knees, and then they'll say it's the data, and I don't understand it. I can see the future for you. And the answer actually is, I don't know about the variation. Why? Well, I wouldn't stand, I'm telling you, I would not stand in a room of orthopedic surgeons and dare tell them how many knee replacements they should be doing, because I'm not sure I, as not even a proper surgeon, would get out alive. But what we're doing is asking the questions. So what is it that these data tell us? Why is it that, are there people in Scotland who need a new knee that aren't getting them? Or are there people who perhaps are at the other end of the spectrum? So we're publishing the data. It's all already available, but it's just that it pictorially and in these funnel plots it makes it more meaningful. So last couple of slides, the realistic medicine then has really taken off, as I've described. My own health department, and it was a pleasure to meet Justin and Milton earlier today. We have much in common, and they've really embraced this. So what they've done is they've given me some resource. I now have clinicians in every one of my health boards who are paid a day a week to do the realistic medicine stuff. But what we've also done is we've paired them up with finance leads. So for the first time, I think probably in anyone's experience, there is a finance person and a doctor in the room talking together. Not necessarily talking about saving money, but talking about understanding the system better together. So we've got a little bit of funding for some value improvement projects, and we've also teamed up with people called Value-Based Healthcare, based in Oxford. Sir Muir Gray, the godfather of screening in the UK, has founded this, and we are doing value improvement training for pairs of clinicians and finance leads from all over Scotland. We've started with 14 pairs, so yeah, that many, and we hope to train 200 people a year. They will go back, train the trainer, type idea, and we will embed this value improvement training throughout our NHS in time. And some of it's very generic. It's not taking particular specialties, but it's enabling them to go back and ask the questions in their own home region area, where they understand the local issues. And I know I'm laughing about the variation, and of course there will be local issues, and it's quite appropriate to have some variation. People are not the same. Parts of the country, as you know only too well, are not the same. Solutions will not be the same. But that's why we wanted to take people from each of our areas, train them up so they can find local solutions to their own variation and explore that. So we really, particularly in this audience, need to talk again a little bit, and I hope we can do this in the panel, with adding value. And as I've said already, you can have high quality care, but if it is not appropriate, like Our Lady, I'm sure that surgery was appropriate, Our Lady with the ileostomy, but it was not of high value for her. So you can have appropriate care, you can have high value care, high quality care, but it might not be high value care. And Sir Muir Gray talks very articulately about this graph with benefits versus harms and the point of optimality, and throwing resource at it along the bottom axis there. Eventually your harms will outweigh your benefits, and you need then to stop. Think and stop. And that might be for one individual patient, prescribing more and more and more treatment, or that may be for your health system. And that point of optimality is difficult to to see, difficult to define, and it will, of course, be different. But I think particularly, and that's part of the reason I agreed when Verna invited me, was that this system is publicly funded. This is the public purse's money. In fact, all of you are taxpayers, and therefore it's your money. And that is partly why my system, I think we need to take this really high value care into account. And I think some of the lessons that I'm talking about are to do with our own healthcare professionals understanding more about that, and more about, as I'm sure Braden will touch on in much more detail, that stewardship of resource. So our two overarching principles: strengthening relationships between professionals and patients, I've talked a lot about that, and reducing harm caused by unwarranted variation, and that value-based healthcare. So I'm hopeful to have a really nice conversation with you after that, because none of this, of course, is simple, and if I was standing here with all the answers, you would wonder why you hadn't found them yourselves. And in fact, our mutual conversations in the last 48 hours have made me realise that we do all appear to be moving in the same direction. I was telling Justin earlier about our care opinion in the UK, which I almost sort of forgot because we're sort of used to it there, but it freaked everybody out yesterday, so I'll tell you. So care opinion, you can just Google it. It's a website where people are invited. Anyone in the NHS who's had care from us can just write their opinion down. They just write it down anonymously. And what we have committed to do in Scotland is we will respond. We will respond to whatever you write. So people write everything from, I couldn't get to sleep because the bins close really noisily. Could you get some soft closed bins, please? Right through to the lovely story of the poor old couple. She admitted he falls over at home. He admitted different part of the hospital. They bring the beds into the side room and they're together. Make you cry. And then the bad outcome, waited in A&E, all that stuff. And we reply. So we've fixed the bins. It was easy. We wouldn't know about that because we're not trying to sleep in the hospital. So it's such valuable information. But the other part is then we can see themes. So individual hospitals, the CEO scans these things. And when we started it, everybody thought, no, you can't do that. You can't. People were writing stuff down and everyone being able to see it. It's horrible. We couldn't, they'll see stuff and actually, of course, it's transparent. The people love it. It's learning for our system, and we discover all sorts of things that we would never find out ourselves. So any of you can look by hospital, you can look by dementia or maternity, and so maybe it's a thing that Albertans might like. I leave it with you. So I'll tell you a final story. Molly is 94, and she has multiple comorbidities. She is in and out of hospital a lot, and at her most recent hospital admission, she said that she did not want to come into hospital again. She said, I don't care anymore about being in this place. I don't like it. I like to be at home. Where I am at home is the land that my family have farmed for 50 years. I like to look out of my window and I look at my land. I have my little dog, Corky, and I miss him. I don't like it here. It's busy and crowded, and there are buildings and cars and no nice trees, and I like to be at home. I'd like to go home. And so they said, okay, well, we better go look. You're not that well, but let's go look at your home, shall we, and see what we can do. So her home was a caravan on the land that she really talked about, and it had only half a roof, and the floor was all rotten. And they went back and they said, Molly, that's not home. You can't live there. She said, but I do live there. When you send me home, that's where I go. You didn't ever come before. So you just sent me home, and now you've seen it. You don't want me to. That's where I live. That's where we're living. So they patched it up. This is our continuing care integration thing. The local authority came in, fixed the roof, fixed the floor. They built that ramp. They brought in carers 4 times a day. The carers feed Corky and probably don't walk him quite as much as they should. And Molly is at home, staring out of the window at her land. She now has a fungating breast lump that she doesn't want to have investigated, and she says, Doctor, I'm 94. I have lived long enough. And that is realistic medicine, or maybe realistic no medicine. Thank you very much.